There's lots of exciting new developments in follicular lymphoma. We've seen the approvals of multiple T-cell engaging therapies in patients who've received multiple previous lines of therapy. So we now have 3 separate CAR T-cell constructs, axi-cell, lyso-cell, and T-cell approved in the 3rd line. And most recently, we've seen approvals of 2 different bispecific antibodies, mosunetuzumab and epcoritamab. So in the multiple relapse space, we've moved away from chemotherapy and towards immunotherapy with very encouraging results. With those encouraging results, we're seeing numerous trials testing those types of treatments in earlier lines of therapy. So I think there are at least 8 randomized trials looking at bispecific antibody treatment in either the 1st or 2nd line of therapy. And I suspect that some of those trials will be positive and will start moving these very active regimens into earlier lines of therapy. So much more to come, but for now, we have very active drugs in the 3rd line setting that are improving outcomes for patients with follicular lymphoma. So there's no randomized data to guide us in terms of which to use first, bispecific antibodies or CAR T-cells. You know, both are active drugs. I think that CAR T-cells probably are slightly more effective. If you look at the data side by side, progression-free survival seems to be longer for CAR T-cell therapy, but it comes at the cost of a higher rate of cytokine release syndrome and neurotoxicity. So I think it's up to the patients. For me, I'm prioritizing bispecific antibodies first for many patients just because it's more convenient and fewer side effects for most patients. The one exception would be for patients where there's a concern for transformation from follicular lymphoma to diffuse large B-cell lymphoma. And for those patients, CAR T-cells, which have excellent activity for both DLBCL and FL, are probably a better choice.